Good afternoon, everybody. Welcome to the 10th John Evans Lectureship in Global Health. I'm Howard Hu. I'm the Dean of the Dalla School of Public Health, a faculty at the University of Toronto. And I'm delighted that you could attend this very special lecture and recognize the role Dr. Evans played at the University of Toronto and his global contributions to human health and well-being around the world. I'd like to thank the Mars Discovery District and Ilse Trunicht, who will be here this evening. Ilse, are you here right now? Fantastic. Ilse, thank you for coming, for hosting us this evening, and for the wonderful contributions of Mars to this event. Of course, this is an institution for which John Evans played a key role in creating another one of his wonderful legacies in Toronto. I'd also like to recognize Dr. Michael Dan, who's the vice chair of our campaign cabinet. Michael, are you here? There he is. Thank you very much, Michael. Key member of our cabinet and also the founding benefactor of our new Wakabines Bryce Institute for Indigenous Health. This is the first event that the school has hosted following Dr. Evans's passing in February of 2015. And today's lecture is especially dedicated to his deep commitment to sharing knowledge and improving health globally. I invite you to read more about Dr. Evans in your program. His son, Dr. Tim Evans, Senior Director of Health, Nutrition, and Population Health at the World Bank, is one of our distinguished panelists this evening, and we're thrilled to have him here. I would also like to acknowledge and welcome other members of the Evans family, including John Evans's daughter, Willa Evans Fife. Willa, will you raise your hand? Fantastic. Great to have you here. Thank you for you and your family for making today possible and sharing your vision of a healthy world with our community. Thanks to the generous endowment by the Evans family in 2002, Dr. David Naylor, who is the Dean of the Faculty of Medicine, a member of our faculty, established the lecture. We want to take this moment to acknowledge David and his family for their foresight in establishing this key lecture event. This lectureship hosts and celebrates lively discussions on critical global public health topics, focusing on challenges countries face to improve the health of populations and the University of Toronto's unique role in saving and improving lives around the world. Past lecturers include Stephen Lewis, a Canadian politician and diplomat, Dorothy Shaw, a professor of women's health at the University of British Columbia, our own Ross Upshur, now head of our school's Division of Clinical Public Health, and Peter Singer, who's here today. Peter, raise your hand. CEO of Grand Challenges Canada. Today's lecturer is Professor Prabhat Jha, who occupies our Dalla Endowed Professorship in Global Health and Epidemiology. He's also a Canada Research Chair and founding director of the Center for Global Health Research at St. Michael's Hospital. And by the way, we have the VP for Research at St. Michael's here, Art Slutsky. Where are you, Art? Raise your hand. Thank you very much. Prabhat was selected to give this year's Evans Lectureship because he's a global health superstar, a global health scientist whose research is having a major impact on the health of people living in low and middle income countries in particular. As lead investigator of the Million Death Study, he leads a team of researchers that work closely with health and government authorities in India and now other countries to quantify causes of premature mortality in over 2 million households. Dr. Jha received his medical degree at the University of Manitoba, following which he attended Oxford as a Rhodes Scholar. In fact, we have some other Rhodes Scholars on our panelists today, where he studied epidemiology under Sir Richard Peto, earning his PhD in 1992. He then went to work at the World Bank, leading a team that contributed to the second national HIV/AIDS control program in India. Later, he worked as a senior scientist in health and poverty at the World Health Organization's Commission on Macroeconomics and Health. In 2002, he founded the Center for Global Health Research at St. Michael's Hospital, where he has directed a variety of large-scale public health studies, most notably the Indian Million Death Study. He's also recognized internationally for his work on smoking and tobacco-related mortality. Indeed, I first became aware of Prabhat when he led the commission that published in 1999, Curbing the Epidemic, Governments and the Economics of Tobacco Control, one of many landmark publications he was to lead in subsequent years, such as the recent 2014 paper in the New England Journal of Medicine on the global effects of smoking, of quitting, and of taxing tobacco. In 2014, he received WHO's World No Tobacco Day Award. He's a member of the Canadian Academy of Health Sciences, officer of the Order of Canada, and has received many other honors and awards. Finally, as a fellow epidemiologist with experience working in partnership with marginalized populations in different countries, I am a firm believer in the power of data to illuminate social needs, to reduce health inequities. That's why Prabhat is also one of the leaders of the School of Public Health's new initiatives on big data and population health, which we aim to position the school as a leader in bringing the power of big data to not only identifying but also addressing health inequities here in Toronto, Canada, and the world. I have personally learned a great deal from Prabhat, and I am inspired by his passion. Please welcome Prabhat Jha.
Thank you, Howard. It's a pleasure to be with you today, and I'd like to begin by thanking the Evans family for this very kind invitation. Many of you know John Evans's extraordinary contributions, including this institution in which we're sitting. And today I'd like to focus particularly on his contributions to global health, including a seminal lecture that he gave called the Shattuck Lecture, which was published in the New England Journal of Medicine in 1981, and which I think is essential reading for anyone who's a student of global health. So let me start by my conclusions, which are really two. First is that we have achieved extraordinary declines in premature mortality in the 20th century. And by understanding how these declines have occurred, we might well help achieve substantial declines in this century. And I hope I can convince you that very basic information on counting the dead, describing the causes of death, and quantifying risk factors are central to the achievements that we would like to achieve in this century. Now, I'm going to talk mostly about avoidance of death in young age and also in middle age. Now, middle age, I'm going to define as age 30 to 69. You know, the definition changes as a bit I grow older, but generally I'm going to talk about 30 to 69. And I apologize because I'm going to give you lots of numbers, and that's one of the criticisms of epidemiologists, is that we're number crunchers like accountants. That's not quite true. Accountants have more personality than epidemiologists. But let me start going back about 200 or 300 years ago. And this fellow pictured here, Edmund Halley, in between discovering or documenting comets, dabbled in demography. And what he did was to get data from a small area of Germany and plot, as you see there, survival on the vertical axis against the age attained on the horizontal axis. And what he showed is that in Germany at that time, most of those born would be dead before age 70, certainly. And in fact, close to 40% were dead before age 10. And not much difference was seen by 1860 when the Registrar General of England started to document these same statistics in England. In fact, if you go back to more ancient times, to Roman history, for example, you see very similar patterns, that most of deaths occurred early in life and very few people reached age 70. And it is what Thomas Hobbes once commented: most of human history has been nasty, brutish, poor, and short. But look at the remarkable transformation that occurred by 1910. Child mortality had been halved, and by 1960, child mortality had become rare. And by 2010, in England and Wales, there was a further reduction, particularly in smoking-related diseases and through low-cost treatment, for example, with aspirin for heart attacks, that has led to the phenomenon that 80% of those born in England can expect to reach age 70. Now, this gives a framework for thinking about where other countries are. Basically, the transitions that are occurring in developing countries are occurring at a faster pace than has occurred in England or in Canada. But it's more complete in England and in Canada. But this gives you a framework. Now, if you look at this slide, you see that still, although 80% of those born in England or in Canada can expect to reach age 70, only a minority of those in India, Ethiopia can expect to reach so. And one of the main challenges is, well, how do we get survival to comparable rates that we see in Canada? Well, the first important development very much is the extraordinary declines that have occurred in childhood mortality. In 1950, about a quarter of all those children born were dead before their 5th birthday. By 2014, that's down to 6%. Still, that represents about 6 million deaths out of 135 million births, but extraordinary progress, and is occurring at a more rapid pace than had occurred, in fact, in Canada. Now, this extraordinary progress in premature mortality has been accompanied by extraordinary progress in other dimensions of the human condition. So take life expectancy. Well, Chilean females, as one example, in 1909 had a life expectancy of 33. That's up to about 80. So an annualized increase of 1% per year. And ask you to pay attention to the last column about what is a reasonable improvement per year. And one way to think about this is, well, if we expect our personal investments to grow at a certain amount, or we expect our economies to grow by a certain amount, we should similarly expect decreases in mortality to be about that same level. So it gives you a benchmark. And certainly when I talk to finance ministers or prime ministers, I say, well, this is one way to think about how to improve health or how to measure improvements in health. And look at the reduction in fertility, extraordinary. In the Western Pacific region, it used to be that as late as 1950, women had about 6 children, and that's down to about 2. Intelligence in Dutch males has increased at a slower rate, and physical height also at a slower rate. But nonetheless, there's extraordinary progress. Income is also increased. Now, importantly, the improvements in income are not the main reason by which these improvements in the human condition have occurred. Mostly it's because of diffusion of technology, diffusion of effective interventions, which I will turn to. Now, what are these effective interventions? Well, they vary very much by time period. So prior to 1950, most of the improvements that occurred were because of control of infectious diseases. And those occurred in turn because of simple understanding of transmission. That's mostly in the 19th century, and then more in the early 20th century, vaccines and drugs as they became available, even crude vaccines and drugs. And most of you know the famous example of John Snow, who in 1854 documented that cholera transmission in London was due to waterborne transmission. And this is important because this very basic knowledge was actually quite critical to public health interventions. Prior to that, the English Army had in its official rules that if in the face of a cholera epidemic, they were to march at 90 degrees to the wind as a way of countering cholera. I mean, that's what they understood about transmission. But since the understanding of transmission, crude public health efforts were being able to be enforced. And that includes quarantine methods that effectively were used to decrease tuberculosis transmission. And these quarantine methods, in fact, were the heart of the response to Ebola. They're very much, these 20th or 19th century tools were central to curbing the Ebola outbreak. Now, the situation is very different after 1950 because it involves much more biomedical interventions or biomedical enterprise. So take, for example, smallpox. Well, that used to kill about 3 million people a year, including one of my late grandmother's 12 children, my aunt who died at the age of 3 in the 1930s in India from smallpox, and that disease has been eradicated. Oral rehydration therapies, which were done out of research in Bangladesh at the university at which Tim Evans was the dean of the School of Public Health, have led to worldwide totals from diarrheal deaths dropping substantially. And in many other areas, we've got substantial new technologies that are more widely diffused and used, and that has led to this substantial decrease in deaths after 1950. Now, Sam Preston, a very eminent demographer, noted this phenomenon that at every level of income, life expectancy in more recent decades is greater than in the preceding decades. So just take, this is life expectancy per level of income, and the income is adjusted for inflation. So take it at a level of about $5,000. Well, worldwide, that would lead in 1930 to, or 1900 to about a survival of no more than about 55 years. But that same level of income by 1990 would give you about 70 years. That's the Chilean female example. So this upward shift in the survival curve has been actually quite a profound influence on thinking about global health. Now, those of you that are chemists in the audience might recognize this as a basic enzyme curve. Basically, as you add more substrate, the rate of the enzyme catalytics increases. And Ryan Hum, a PhD student at the University of Toronto, did a very clever analysis where he applied these classic enzyme kinetics to the Preston curve. And we looked in particular at child survival. And what you see is that the costs, which in this case is defined as how much money do you need to achieve about half of the maximal survival in that year for children. How much do you need? Well, the marginal cost, in fact, are falling over time. Now, why is that? Well, this is the classic technology curve. You see it, for example, in cell phones or in computer or in travel. The marginal cost of doing things is getting cheaper and cheaper. And it's, I think, partly for this reason that Bill Gates has personally invested this idea that in his lifetime, he would like to see child mortality come down from 6 million deaths to something like 2 million or 1 million deaths. And he's bet on the right horse because the technology curve is favorable. Now, by contrast, adult survival, which is adult male survival at 15 to 59 years, is getting more expensive over the same time period. Now, if you take this curve and take out two big epidemics, HIV and tobacco, the curve flattens, but it doesn't come down. And I attribute this to precisely the same reasons as we've had progress in child mortality, which is because of a substantial research and development enterprise, diffusion of efforts, has not yet been done for adult survival. Okay, well, the central challenge going forward to 2030, when the UN has declared these Sustainable Development Goals, is to reduce premature mortality for adults. At current, global life expectancy is about 70 years. And so the key question is, at 2030, could we aim to get something like Canadian survival today, meaning about 80% of those born would reach age 70. To do so, that would require about a 40% cut in death rates in 2030 versus 2010. Now, is this achievable? I think we can come back and discuss that. But one of the central ways of trying to achieve that extraordinary reductions in mortality is very basic, is to understand how people die in developing countries. Now, there's about 56 million deaths a year worldwide, most of which are in low-income countries, and most of which are in adults. And for those audiences, for those populations, we simply have inadequate information on the causes of death. For example, only 3% of the world's children who died in 2010 had a medically certified causes of death. And this is in the context of weak systems for monitoring deaths. Now, the solution for this, of course, would be to get all deaths registered and medically certified. But that will only occur when deaths start occurring in hospitals. Most deaths occur at home and in rural areas currently. So for decades, we have to think about some interim solutions. What is an interim solution? Well, one was proposed, interestingly, in 1869 by the Sanitary Commissioner of the Government of India, who argued that for sanitary purposes, it is indispensable to know the relative mortality in small and as far as possible, well-defined tracts, to ascertain the death rates and to apply the remedies. Effectively, that's what we're doing in the Million Death Study. So working with the Registrar General, we survey about 1 million homes all over the country. It's a true snapshot of India. Non-medical teams go and collect standard information on each of the deaths, and they get a half-page local language narrative. This then is looked at by 400 doctors using online coding systems and using strict guidelines and quality control. And the approach is very much to study all diseases, work with the Census Department, and keep things really cheap. The entire effort costs less than $1 per home per year. And more recently, we've moved to innovations like having laptop-based entry and using GPS tracking. But the heart of this is really a simple one: knocking on a door and getting a respectful conversation with the household as to what happened and understanding those. What have we learned from the Million Death Study? Well, pretty much anything important for public health has been documented in this study. For example, that in India, unfortunately, about 4 to 12 million girls have been aborted before birth since 1980, and half of which are just in the last decade. We've documented, as I'll show you, much larger number of smoking deaths than expected, but also some good news. For example, HIV deaths in India are only about 100,000, which is substantially lower than had been based on projections by the UN, which said there were about 400,000. And more generally, every disease that's common in one part of India is rare in another, and that suggests there are avoidable causes that await discovery. Let's look at child mortality. Well, India's gone from 2 million child deaths a year in 2005 down to 1.2 million. And there's been extraordinary progress, particularly in 1 to 59-month mortality, slower progress in the first month of life. And you see the difference between rural and urban areas over that time has narrowed. It used to be 1.7-fold difference between rural and urban areas, but now you see that's down to about 1.2. And extraordinarily, the gender gap between mortality at these ages has also narrowed. If you come to particular diseases, there's extraordinary progress. So again, if you think of that metric of an annual decline being as favorable as the economic growth that prime ministers and finance ministers aspire to, performance has been very good in India for child mortality. That's 4% a year decline in all cause. And for some particular causes, pneumonia or diarrhea, it's about 8%, just extraordinary. You get things like tetanus and measles, which have come down 19% a year. I mean, that is extraordinary. Mr. Trump would claim only by going to Trump University could you achieve that kind of return, but public health can actually do so with very simple interventions. Now, the news is not all good, because you see at the last or the second last row an increasing burden of prematurity and low birth weight. This is in the first month of life. That's going up 2% a year. And similarly, at older ages, at 15 to 69, heart attack deaths are going up 2.4%. And aside from favorable reductions in chronic lung disease, about 3% a year, the overall adult mortality declines are 1% a year. And again, I would submit that if you asked a finance minister or prime minister, is that an acceptable rate of income growth, they'd say no. And we could use the same logic for public health. What we should be aiming for is much faster reductions in these chronic diseases. Well, how do we get there? A key pillar, and I think an important shift, is to recognize that not just prevention, but treatment of chronic diseases is needed. And in the last year, we have done with the Gates Foundation a global review of cancer control, which is called the Disease Control Priorities Project. And this recommended for cancer, for common cancers in the world, not only effective prevention through tobacco control, which I'll come back to, hepatitis B vaccination, and very excitingly, hepatitis or human papillomavirus vaccination, but also treatment for common cancers, cervical cancer, breast cancer, and selected pediatric cancers, paired with palliative control and pain control. This would cost about $20 billion a year, which is affordable in many countries, about less than 5% of health budgets. If you want to look at the impact of widespread treatment on common cancers, look no further than what's happened in Canada or in the UK on breast cancer. Because of a series of small efforts on hormonal therapy, on chemotherapy, and radiotherapy, all put together, plus a reasonably organized delivery program, breast cancer mortality in Canada and in the UK has fallen by half because of a series of these cumulative effects have in total led to substantial improvements in survival. Similar approaches applied to treatment of those with existing vascular disease. In the Million Death Study, we found that most of those 1.3 million deaths from vascular disease had a previous history of disease. And it suggests that if you could get them on simple combinations of aspirin or blood pressure lowering pills and statins, you could reduce a 10-year risk of 50% with no treatment down to 16% with 3 drugs. And that's highly effective. If you ask anyone, would they be willing to take 3 pills a day, or ideally 1 pill a day for the rest of their lives to get that reduction? I think most would say yes. Okay, I'll skip this in the interest of time. Let me turn to risk factors. And the big important risk factors for chronic diseases are binge drinking, obesity, and smoking, which I will turn to in the last part of my comments. So on drinking, the message is pretty clear. Don't drink like a Russian male. If in most countries, smoking mortality exceeds binge alcohol mortality, but not so in Russia. And David Zaridze and Richard Pito sorted this very nicely in Russia by studying in Siberia what were the patterns of deaths among Russian males and what did they drink. And if you want to know what a Russian man drank accurately, ask his wife after he's died, and you get a right answer. So what they compared was men who drank a bottle of vodka a day, those were the cases, versus the controls who drank only half a bottle a week. They couldn't find any non-drinking controls. So, and what you see is an extraordinary excess of the most common conditions, such that the rapid fluctuations that have occurred in Russia in mortality are very much due to binge drinking, at least in recent decades. And this finally is spurring the government to take some action. Okay, what about obesity? Well, severe obesity, meaning body mass index of about 43, does lead to about the same loss of life of 1 decade as typical cigarette smoking. Now, however, severe obesity is reasonably uncommon, even in the United States. Only a small portion of the population are severely obese. So take me as an example. If I've got a body mass index right at 24, if I were to gain 50 kilograms, I would get the same loss of life as if I were a typical smoker. More modest obesity of about 25 kilogram gains means about a 3-year loss of life. Now, this refers to adult obesity. The effects of childhood obesity might well be more substantial. But we don't know so much about how to get people to lose weight. I mean, I think many in the room would attest to that. But we do know how to get people to quit smoking. What we do know about body mass, however, is the main mechanisms by which it increases vascular disease, which are really through higher blood pressure, raising the bad cholesterol, LDL cholesterol, lowering the good cholesterol, HDL cholesterol, and most importantly, perhaps the contribution to diabetes. And in this area, we're learning more and more about the impact of uncontrolled diabetes. So take India, where diabetes treatment is really substandard, and we've looked in the Million Death Study of the odds of renal deaths. This is Anna Dare's work that looks at renal mortality. And of the roughly 180,000 deaths from renal failure a year in India, you see that the odds of dying, which is shown on this doubling scale, are substantially greater in men and women born in the 1970s than in the 1960s. I mean, those risks are increasing, meaning the younger cohorts are getting greater risks because of the diabetes exposure. By contrast, for hypertension, you don't see as demonstrable increase in the younger cohorts. And similar results are now emerging from Mexico, suggesting substantial loss of life from untreated diabetes. Well, let me turn to smoking. Well, in the last decade, smoking caused about 100 million deaths. In this decade, on current patterns, it'll cause about 1 billion deaths. And one way to think about this is really the astronomical amounts of cigarettes smoked. If you took all the cigarettes smoked in the 20th century and you stacked them and said, well, how far out does it reach in the solar system? You would get roughly past Neptune for the 20th century smoking. If you look at 21st century on current patterns, it would go well past Voyager. This is a log scale, by the way, if you noted, and this is in astronomical units, meaning each value of 1 represents the distance from the Earth to the sun. So it's extraordinary amount, and if just China alone would be something like a third of that total, meaning it would exceed where Voyager has reached in terms of the consumption. So the extraordinary amount of smoking, although it's been well documented, we've only learned recently the full effects of prolonged smoking, surprisingly recently. And this is the 21st century hazards, which now have documented in men, and importantly in women. Women didn't start to smoke seriously like men until about 2 decades after most men had started in high-income countries. And that has meant that only recently have we been able to document the full effects in women and in men. And surprisingly, at a meeting that we had in the honor of the late Sir Richard Dall, we showed that across about 6 studies, there was remarkably consistent loss of life, about a decade of life lost for prolonged smoking for men and women. And this is how Brian Williams from NBC covered one of these results.
And good news and bad news on the smoking front from the New England Journal of Medicine. They state flat out smokers lose at least 1 decade of life expectancy over non-smokers on average. The encouraging news here is quitting before 40 reduces the smoking-related death risk by 90% compared to continuing on as a smoker.
I love that. That's 66 years of epidemiology in 22 seconds. And it's exactly right. That's the key message, is that now the contemporary risk, which we've looked at in the US population using a very novel study that uses the National Death Index, which I call the Facebook of death or death book, showed that women who smoke like men die like men, now with mature risks about 3-fold higher. And that in terms of survival, the probability of a 25-year-old woman in the US living till age 80, you can't live forever, but living till age 80 in good health is a reasonable proposition, is substantially different. Among never smokers, 70% do reach age 80, but among current smokers, only 38%, leading to about a decade of life lost. And it's similar now to men. Okay, well, that gives a framework for understanding where the tobacco epidemic is maturing in other populations. For example, in China, the proportion of deaths in men, women don't smoke, thankfully, in China, but in men, about 12% of the deaths in the 1990s were due to smoking. That's gone up to 20% and greater in urban areas. And we can reasonably predict what would be the mature epidemic, which would be about a third, which is about the US average at its peak, and also what Hong Kong, which started smoking about 2 decades earlier, has already achieved. In India, surprisingly, although smoking is less prevalent, the risks seem to be as big as in China. So men who smoke the Western cigarette lose now about a decade of life. And this is important because the cigarette is displacing other types of tobacco smoked in India, including the bidi. And what this has meant in part is that for the risks between smoker and non-smoker are getting more extreme, particularly for tuberculosis and respiratory diseases. Okay, because the effects of smoking are so big, the benefits of quitting are ridiculously large. And if you quit by age 40, you get back about 90% or you reduce the excess risk by 90%, or you get back roughly 9 of the 10 years of life lost. But quitting by 50 reduces the risk by 6 years, and quitting by 60 reduces the risk by 4 years. And this is important. In Canada, there's still about 4 million smokers, and many of them believe, well, it's too late for me. There's no point quitting, but in fact, the benefits of quitting are substantial. Where there has been quitting, as I will now show you for across North America, there is a substantial reduction in deaths from smoking. So these are Ontario data from ISIS, and they show that in men and in women, there are substantial decreases from smoking. But look at the decrease in men. Well, smoking attributable deaths, which is shown in the dark bar, has decreased by about 40%. And that's a greater decline than the decrease in overall mortality, which is shown in the total bar, the white plus the shaded, which is decreased by about 25%. And similarly for women, the overall decline is about 25%. But importantly, the decline in tobacco deaths is smaller than in men. It's commonly misunderstood that, well, we've got smoking under control in Canada. Well, it's not true, and it's particularly not true for women. Adult cessation by women is actually much worse than in men, and that's an important public health strategy going forward. If you go south now, the comparisons really vary by race. So among men in the US white men have also had about a 40% decline in smoking-related mortality. That's shown in the dark bar. And interestingly, in US blacks, the 2015 risks look like the 1995 risks for US whites. They're about 20 years behind. But look at the extraordinary decrease that's occurred in overall mortality in US blacks. There's actually good news about the extraordinary decrease, not just from tobacco, but from other causes that has occurred in the US black population. So there is some convergence occurring in those populations, even though there are substantial gaps. Let's keep going south to Mexico. And in Mexico, smoking is really a major concern just in the northern states of Mexico, where lung cancer is reasonably established. And you see this extraordinary decrease also in the tobacco attributable proportions, such that in Mexican high burden states and among US Hispanic men, the risks of smoking-related deaths are actually now similar, about 2%. But look at the extraordinary differences. In Mexico, the overall probability of death has not changed much, and that's due in large part to the effects of untreated diabetes, whereas among US Hispanics, with better access to healthcare, diabetes is treated. And you see that thin red line is the effects of gun violence in the US and in Mexico, and particularly in Mexico, that's actually not been inconsequential. Okay, well, it's said that death and taxes are unavoidable, but they don't need to be in that order. You could have higher taxes as a most effective strategy to reduce consumption. And in Canada, it took us about 35 years to have consumption of cigarettes. But France was able to have consumption in 15 years. And they did it because of substantial price hikes above inflation every year, which is shown here, that Jacques Chirac raised the price 5% above inflation every year. And that's led to a substantial attenuation of tobacco consumption, but also of tobacco deaths. And this is relevant because Bill Morneau, the finance minister in Canada, is considering a large tax hike, and Ontario's government would do well to partner with that hikes. Now, there are other interventions for smoking which are also very promising. The University of Toronto's own Jane Philpott, the Minister of Health, has been charged with introducing plain packaging in Canada. And the Australian evidence, which is the example of the labels here, shows that that actually would raise quit rates. And that's important. Canada has been actually a pioneer in warning labels and introducing, for example, this one, tobacco use can make you impotent. And there's been studies that if you hand a pack of these to a man, they'll say, no, give me the one that says it'll kill me. They prefer, so it does have some impact. So now going forward, what's the overall scenario going to 2030? Well, at current death rates, in 2030, there'll be about 20 million deaths before age 50 and about 20 million deaths at 50 to 69. If we achieve the reductions that have persisted in the last decade, but I think as I showed you from the million death study, that's not necessarily certain given the effects of smoking and obesity, you could get about a third reduction. If there were major efforts, such as the UN has proposed, the UN targeted gains, we could reduce premature mortality by 40%. Now, the difference between that is 30 million deaths versus 26 million deaths, so 4 million deaths. That doesn't sound like a lot, but I'd submit that death is so depressing that even a modest increase in that magnitude would be worthwhile. So let me return to John Evans's contribution to wrap up. Well, I don't want to pretend to be an economist, and I'll be careful what I say about economists because I'm married to one. But if you look at what John in his Shattuck lecture outlined very broadly, was that reduced child death, and he focused on child death, was really a function of total expenditures, appropriate technology, drug policy, and good health management. And when he wrote it, that was a time where there was a large poverty constraint. Much of the world lived on less than $2 a day. Since that time, and I think no one could have predicted, including he, the extraordinary progress that has occurred in absolute poverty. The number of people living on less than $1.25 a day has dropped by about 1 billion, as shown in this graph from The Economist. So what would it look like today? Well, I'll suggest an update, which is for discussion. Again, this is very simplistic, but it suggests that if the goal is total premature deaths, then of course spending matters, but what also matters is the bad spending, the out-of-pocket private expenditure, which I no doubt our colleague Tim Evans will refer to because he's done some really good work in this area. So we have to get people to spend less on inefficient private types of spending. And I will submit that disease-specific research and development is much more important than we have estimated in the past. That's why I squared the term. I think it's actually far more important than we have estimated. And data to monitor outcomes, like the Million Death Study, but other efforts. And this is all within a smaller poverty constraint. Where do I back this up? Well, Rand Corporation did an interesting study of some countries in 2006, and they came to these conclusions. You don't need economic growth. You don't necessarily need good political will or good governance. It doesn't doom efforts. Technical assistance is particularly important, and it took a dig at WHO and the World Bank, saying those comprehensive frameworks actually are not necessarily productive. An earlier voice was that of Kingsley Davis. This was a fellow who was interested very much in the same things in which I'm interested in, but just 60 years earlier. And I went down to his archives at the Hoover Institute in Stanford, and one of these publications that he had this quote, which is in 1956. It seems that the great reduction in mortality in developing countries since 1940, he was particularly looking at the post-World War II era, is mostly due to the discovery of new means of disease treatment applicable at reasonable cost and by diffusion of these new methods. This reduction is rapid because it did not depend on general economic development. And later he goes on to say, although there's great lip service paid to the necessity of general economic improvement and community welfare in the control of disease, the truth is that many scourges can be stamped out with none of this. Well, I certainly subscribe to that view. What are we doing about this in the last couple of slides about these efforts? Well, in Toronto, we formed the Statistical Alliance of Vital Events, which is to try to expand the kind of solutions we've achieved in India with the Million Death Study to other countries, starting with Ethiopia and Mozambique. And the goal is to try to expand that to other countries. We've also formed a Lancet Commission on Global Tobacco Control, which aims to accelerate tobacco control. And the idea is to change behavior of finance ministers to adopt taxes. So let me add one more conclusion to what I had started with, which is that John Evans's ideas remain relevant today, in addition to what I've prescribed, which is large declines in premature mortality and counting the dead. And I hope I've convinced you that one of the best ways to help the living is to count the dead. Thank you very much.
That was fantastic. And Prabhat, you showed a lot of statistics, and it's going to be a challenge for our panelists to go through that material. Sometimes I try to boil down the take-home message from this, and perhaps a whimsical take-home message from all the statistics you showed is that if I only drank half a bottle of vodka, I'd be okay. And if I was going to take up smoking, as long as I took Viagra every day, I'll probably be okay on that score as well. I'm going to welcome first the chair of our panel, Stephen Toope, introduce him, and he'll introduce our panelists briefly. We're very, very fortunate to have Stephen moderating the panel today. Not only is he a noted international law scholar and university leader, and the director of our Munk School of Global Affairs here at the University of Toronto, but he was the past president of the University of British Columbia and brings all of that wisdom about how universities operate in relation to how we do scholarship in this area. He continues to conduct research in international law and is currently working on issues of continuity and change in international law and the origins of international obligation in international society. Please welcome Stephen Toope.
Thank you very much. It's an honor to be here and to preside over such a distinguished panel, as you will hear in just a moment. I'm going to introduce the panel very briefly because I'm sure you'd rather hear from them than about them. Paul Cadario had a 37-year career at the World Bank, serving the bank on 5 continents. And you're going to see that there are certain themes in these introductions. One is World Bank, the other is Rhodes Scholarship. Very interesting. Paul is now a Distinguished Senior Fellow in Global Innovation here at the University of Toronto, cross-appointed at the Munk School of Global Affairs and the Faculty of Applied Science and Engineering, awarded an honorary doctorate from U of T in 2013. He's a terrific colleague and a Rhodes Scholar like Prabhat. Next is Jillian Kohler. Professor Kohler is at the Leslie Dan Faculty of Pharmacy, the Dalla Lana School of Public Health, and the Munk School of Global Affairs. Founding director of the World Health Organization Collaborating Center for Governance, Transparency, and Accountability in the pharmaceutical sector. Her research is focused on fair access to essential medicines, with a particular focus on good governance and intellectual property rights. And she also worked at the World Bank in an earlier part of her life. Dr. Timothy Evans is the Senior Director of Health, Nutrition, and Population at the World Bank Group. And from 2010 to 13, he was Dean of the James P. Grant School of Public Health at the BRAC University in Dhaka, Bangladesh. Before that, Assistant Director General of the World Health Organization, and before that, Director of the Health Equity Theme at the Rockefeller Foundation. And finally, Borys Chabursky, who is the founder and chairman of Shift Health. Mr. Chabursky specializes in strategic planning, fundraising, financial management, business development in biotechnology, medical device, imaging, oncology companies, science and technology. He's worked with hundreds of clients, 500 life sciences assignments, also providing management leadership in startup companies, angel financing. So we have a panel with extraordinary breadth of knowledge, and I'm looking forward to hearing from them. After they speak, each for roughly 5 minutes or so, then we'll have time to open up to questions from the floor. Join me in welcoming our panel. Paul, let's start with you.
Thank you, Stephen, and thank you, Prabhat, for a great appetizer to our discussion this afternoon. It's also a great honor for me to be here at an event in honor of Dr. John Evans, whom I met in 1972 when he was the president of the university, and I was a third-year student about to work with him when he became president, and I was on the governing council. And I remember going to the highlands of Papua New Guinea with John, and John had me do rounds with him in a hospital that did leprosy, except I didn't know it was leprosy until he told me who I just examined. So John was like that. But John was a doctor and a health professional who believed in getting evidence and data. And the best way to get it was to go and do it yourself. And a lot of what Prabhat said this afternoon was about data and how much we've learned about the improvements in global public health. But a lot of this was about developed countries with very well-organized health systems. Now, well is all relative, and at the School of Public Health, as an engineer, I'm going to be very careful. But a lot of this data comes from people doing great studies, WHO, charitable sector. But if I'm a public health professional in Guinea, or in Timor-Leste, or in, I don't know, Mozambique, and I have to deal with sick people every day, and somebody comes in and does measurement, well, okay, that's great, it gets into a study, but shouldn't I be involved in collecting that data? Because it's data that's important to me and my patients and my director and her director and the deputy minister and the minister, because that's how they influence the course of public health decision-making in the country. Whereas if people come in and do the study, well, that's fine. But I think that if I collect data that's important to me, or I'm sort of shown, well, this is really important data, or people come and say, well, what is your information about this? That I may own it, and if I own it, I may do something with it. And so I just put the question out there, does more need to be done to get this data down to the diseases, to the populations, to the countries where more data would lead to better treatment and would lead to better outcomes? Because that's really what it's about. And all this global data is very good, but how does that knowledge get transferred? And that, I think, is another point I'm just going to throw out there. Having worked at the World Bank for so long, I have a fair knowledge of organizational learning issues. And the World Bank, and I'll just say, looking at epidemiology and global pandemics and all the things that we talk about today, I just wondered the extent to which organizations that worry about this every day actually learn from what's happened. And even if they, in all good faith and with all great technology and with honest people and peer review, get really good studies, and then they present them to the development partners, as we call everybody now, and the development partners say, oh, those are really good recommendations. And then there's another bright, shiny object that distracts them from those recommendations, and then there's another incident which, oh my God, look at the cost of this, and oh, Anderson Cooper's arrived, it must be a problem. Whereas, say, $3 million worth of lab testing, build a lab, train the technicians, get the process for disease reporting in place, might have brought some public health dilemma, crisis, to somebody's knowledge 3, 6, 8 months earlier than when Anderson Cooper arrived. And there are studies like that. So the data are fine. We've learned a lot. There's much that's been learned that can be introduced to other countries. But have we got the learning systems in place so that those data actually lead to better results for underserved communities. And I'm not sure we do, despite all the money and all the attention that's been lavished on public health and in general economic development. And we have the Sustainable Development Goals. We have the opportunity to do better in the next 14 years, and I hope that we do. Thanks.
Thanks, Paul. Jillian.
Thank you, Stephen. I also want to say thank you to Prabhat for his excellent lecture, and also I'm honored to be part of this panel today. There's a lot that I'd like to say. I'm going to take a cue from Dr. Jha, and he did mention in his talk the importance of treatment options. And for me, that calls to mind access to medicines. And when we think ahead of making progress, what I'm troubled by is the fact that in all the years that I've been working on some of these issues, we still kind of throw around these very limited numbers about the global drug gap. And Paul, you were mentioning data. I'm interested in an area where there's really, what do you do when there's not a lot of data? And I think the pharmaceutical area, which is key for progress in health development, and was something that Dr. John Evans signaled in his lecture in 1981, needs to think about the invisible. And the invisible here is the issue of governance and institutional design. And because of I would argue there's been a lack of attention to some of these challenging, what are also known as global wicked problems, which are embedded in the pharmaceutical system. We really haven't made as much progress as we ought to. So just take an example, which Prabhat highlighted, one which many of us are aware of, in terms of access to antiretroviral for those living with it. When we think about today, there has been tremendous gains. There's no doubt about that. Yet there's 22 million people still living with HIV who are not accessing therapy. And when we think about children, access to therapy is actually devastating in terms of the low numbers, 54% in Latin America to 15% in the Middle East and North Africa. We know that improved access to medicines and vaccines saves lives. WHO estimates about 10 million per year. So the question is, why are we still dealing with persistent and inexcusable drug gaps? What I would submit is that we have a problem when we look at development policies agendas. And in terms of medicines, the experts, so to speak, have traditionally focused on areas such as infrastructural limits to service delivery. Yet there's an increasing body of evidence that illuminates how governance challenges, something that I'll take issue with Prabhat's point that good governance doesn't matter. You invited me to critique, so I will critique, and I will argue that, in fact, I disagree. I think good governance matters a lot. And I would argue in terms of looking at the drug gap, it's not the reason why we have one, but it is one of the issues. What do we do about it then? I also wanted to just throw out, because I am dealing with epidemiologists, and some of you in the audience might like statistics. I came across this great figure about yesterday or the day before on the Sustainable Development Goals website, which quoted that corruption, bribery, theft, and tax evasion are estimated to cost about US $1.26 trillion for developing countries. So just think about the fact then that the invisible matters. Some of this has come to light recently with the Panama Papers, et cetera, but it's still not enough. Going back to the pharmaceutical sector, we have issues with it because it's a very lucrative sector, and the global pharmaceutical market can inspire corruption from those who are nefarious if good governance, and here's my point again, it matters if it's weak or non-existent. And how is it infiltrated? Well, it's infiltrated by forms of corruption that's such as bribery, theft, and collusion. And what happens with that? Well, that undermines global health gains, which is what today is really about. And that, in turn, undermines institutions and their interventions, and it also tarnishes political credibility. We have a sector with drugs, which is key to global health, but it's also very challenging to govern. There's multiple opportunities for system failure, limited accountability, and coordination. I'm going to close up. The bottom line here is that when we think about how can we make gains, institutions matter. We need to make sure that development institutions, which in the past have traditionally ignored the area because there's limited data, it's hard to quantify, it's invisible, as I've mentioned, and also it's a very politically sensitive issue, it's tricky to address. What's helpful, and I'll close here, is that in fact the issue of corruption, its importance not just for global health but for development in itself, has actually gotten on the global health agenda most recently with the Sustainable Development Goals. So we only need to think about the fact that we now have an SDG number 16, which talks about institutions, its importance, and also the fact that corruption and its forms need to be eradicated. So I'll close with my last point. Shining light on corruption, making the invisible visible will matter for global pharmaceutical access to good quality and needed medicines and avoiding avoidable deaths. Thank you.
Thanks, Jillian. Tim.
Great, thanks. First, let me thank Prabhat for a wonderful lecture. I think he's taken the whole area of epidemiology to new heights and scale. I've never seen as many cigarettes stacked up, and he's redefining epidemiology as rocket science, clearly. But that was very good. And, you know, I had the misfortune of studying economics, which many people refer to as the dismal sciences. But it always made me feel better when I was around doctors who were studying the deathly sciences. And clearly, Prabhat, with his million death study, as the doctor of death. And so it makes us feel much better. I mentioned The Economist because one of the co-authors in the Shattuck lecture, Jeremy Warford, was an economist who I had the good fortune of meeting about 2 years ago when I joined the World Bank. And he confided in me that when he was sent to work with the new Population Health and Nutrition Division under this Dr. John Evans, he felt he had been sent to the gulag because he felt it was a demotion. This was health. This had nothing to do with real economics. And he said that one of the benefits was that he learned something about epidemiology. And what he learned, most importantly, was the classic epidemiologic study done on smoking in physicians in the UK, and this evidence of a dose response, which is the more you intake, the higher your risk of death. And this was something he hadn't learned in economics, and he said this actually, when he left the Population Health Nutrition Division, this really was something that improved his ability to be a development economist at the World Bank. So let me use that as a segue to make my 3 points over the next 30 minutes. The first point, I think convergence and divergence is really an excellent theme, and I think, Prabhat, you've brought that out. I'd like to add to that, which is divergence and convergence is an attention to distributions. And those distributions often are not fair or unjust. And that's really what causes a concern. These aren't choices that individuals make, but they're often the consequences of not having the social circumstances that allow them the opportunities for health. And so let me give a few examples that I think are particularly important in this regard. You mentioned sex ratios at birth in India and the missing girls. And this relates to prenatal sex selection through ultrasonic determination of the sex of the fetus, usually, but not always in the first trimester. If you look at that pattern over time between 2001 and 2011, both in India and in China, the sex ratio of birth has become more skewed. So the likelihood of the female fetus being selected out by modern technology and opportunity and cultural preference is growing, not diminishing, in the two largest countries in the world. So there's a real issue of fundamental inequities. If we look at those Russian men who drink a bottle of vodka a day or a week, and I was told by a very good friend of mine that the highest blood alcohol levels ever recorded on Earth have been found in Russian men. But if you look at the circumstances of those Russian men, the vast majority of them did not go beyond high school education. So a very strong association with low levels of education and employment insecurity. So these conditions, these broader conditions, are extremely important in understanding whether or not you're going to have divergence or convergence. And really, I think your small area variation and understanding of those patterns is absolutely fundamental to accelerating progress more fundamentally. Two other points. The second one is that technology and numbers are absolutely important, but the political will to finance a health system as it should be financed is important. And you mentioned Canada in some of your comments, and I think often we think of Canada as the health system that every other country would like to have, especially when we're working internationally. But we shouldn't forget that it was Tommy Douglas who brought the opportunity of a universal system for everyone. And that opportunity of universal access is one that most countries don't have. And that's where we see Prabhat's very good inclusion of concern about out-of-pocket expenditure. Because that way of financing systems, pay as you go, when you're sick, accounts for pushing 100 to 150 million individuals into poverty or keeping them in poverty every year. So this is doing harm. The way in which the health system is financed is actually regressive. It's taking opportunities away and indicting them to poverty. As Tommy Douglas said, it's wrong that you have to sell the farm when you're ill. And that's what led to the health reform in Saskatchewan, which the doctors didn't support, by the way, but which, thanks to others, including doctors from the United States, who rallied around Saskatchewan, led to a domino effect and gave us the universal system in Canada that we too often take for granted. Last point. It's not simply about the right interventions, and I think, Paul, you were getting to this. It's really about how you deliver them. And that requires an attention to what some call as the science of delivery. It's the how do you scale up interventions that you know are effective. And Angus Deaton, another dismal scientist who just won a Nobel Prize, gave a lecture in Stockholm in 1996 in which he examined those Preston curves, those curves that, as you said, look like some sort of chemistry experiment, Prabhat, but where we're seeing that over time, the efficiency of gaining gains in health with income are increasing. But his conclusion from that was that it isn't the level of wealth that determines opportunity in a country. It's how societies organize their social and economic assets, including the organization of the health sector. And I think that's a tremendously empowering opportunity, which is wealth doesn't need to be the constraint to improvement. There's a tremendous amount that you can do if you think actively about how you organize those resources for the benefit of those most in need. Thanks.
Thanks very much, Tim. Over to you, Boris.
Thank you. So I'm kind of not an academic by any stretch, definitely a capitalist at heart and in deed. So I might take a slightly different stance on a couple of these points, although I think they'll marry quickly to what's been said already. So first, I wanted to thank Prabhat for inviting me, and obviously for a fantastic lecture. And I also, reflect when I was reflecting on this, thinking about the times when I met John Evans, who was a fantastic mentor to myself and to many others as we were growing. And my quick 30-second anecdote was really, I was talking to him one day. We got into a discussion. He brought me in saying, "What's new? What's happening?" And I told him about an investment that I made that had completely blown up. And I was sitting there and walking through, and I was actually hoping for, some amount of commiseration, maybe a hug. And he looked at me and goes, "Great, that's fantastic." And I kind of stopped and I said, I don't understand. I mean, are we having the same conversation here? I just told you how and he goes, "You'll never make any of those mistakes again, will you?" He goes, "You just grew up, you just got your MBA, and off you go." And it was a fantastic way of approaching it. It's something I'll remember forever with regards to, view of looking at exactly what you do. Take every step and learn from those pieces, whether kind of mistakes or not. So I wanted to talk a little bit about data, which we talked about. We talked about predictability of data. And if you think from a capitalist perspective, what do we want? We, as people that are investors into companies, you're looking for predictability, and you want to have something that you can kind of lay against, that there's data that's accurate and been accurate collected, something that Prabhat had talked about. So, and I think that levels on some of the things that Jillian had said about governance, and Tim, you've talked about financing and organizing on the healthcare system. And so my question really was whether, given the presence of great organizations like the WHO, given the presence of Gates and other charitable organizations, have the changes that have occurred so far in the last little while occurred despite structural changes, but are we coming to a limit whereby if we do not have structural shifts from a healthcare system perspective in developing countries, we're actually going to achieve a point where the costs are actually going to increase and not decrease? And really looking at where is that combination of direct delivery of care that needs to be done right now, so disease-focused precision changes, and then macro changes at the same time. So I'll use one example. I was just in Ukraine got back from Ukraine last week and spent some time with the previous health minister. In Ukraine, very similar to Russia, I mean, a horrible situation with regards to alcohol consumption and smoking. In fact, I learned that the hard way. It is actually kind of rude to leave the table if a bottle's been opened and not consumed. So you kind of try to time it when it gets really low, and you kind of make a run for the exit because you know the next one's coming. So you've got a situation here where corruption is so inherent. It's a system that is broken. You have 16 tiers. You have fiefdoms that actually are controlling the healthcare system, and doctors do not make a lot of money, and in fact, people are encouraged to bribe their physician. The more you bribe, the better the service. The further you're going to get, the more care you're going to get delivered, and that actually determines whether you, as an adult especially, get care, and at what level do you get care. And that kind of inherent corrupt system is ineffective. And in fact, I was talking to someone from a country who has a business that deals often in corruption, and he goes, "You know what, Ukraine is the most corrupt country I've ever worked with, not because corruption is there and my country doesn't have it, because it's unpredictable. You actually don't know what you're going to be asked for. There's no way of systemic corruption, so it's even getting worse from that perspective." And I think that if you've got to look at it from that perspective. So what can you do? I think you need organizations going back to things like John championed, like CFI. You need a larger macro-based moonshot that allows Western-based philosophy with regards to delivery of care and health system management to be able to be applied to markets in emerging countries. So yes, you need those precision cares, but you need large-scale infrastructure and structural change that has to be forced top-down. If you don't have that top-down approach, you actually will at some point hit that point where you can't actually deliver the changes that you're going to want, and you're not going to actually have the decreases in mortality that you're looking for. And I think from that perspective, unless you actually start making those changes, you can't effectively work with industry. Industry could be a great partner in these types of situations, but they will not actually engage in a situation where they do not know predictably what the outcome will be. And as a result, you actually do not get the values. So you don't have efficiency, you don't have effectiveness, and you're not leveraging what you could leverage from the players such as industry. So I'll stop there.
Thanks very much, Boris. We now have time for a few questions, and there are microphones on either side, so please come up and pose any questions that you'd like to pose. And I would ask that you identify yourself and make the question of an interrogatory nature, please. Prabhat, why don't you come up and sit here in case there are questions directly to you as well?
I'm Bernard Choi from the Public Health Agency of Canada in Ottawa. Thanks, Professor Jha, for such an excellent lecture. I like the vodka slide. It reminds me of a slogan I saw in Mexico. We have been on a tequila diet, and we have lost 3 days. My question is, it is good to track millions of deaths, but should we also add other dimensions like the quality of life into consideration, into the tracking? 3 considerations. Number one, in the last several thousand years, the way how people die has changed. If you get an infectious disease, you die in 2 weeks. The effect on quality of life is minimal. But now, as the life expectancy extends, people are more in a poor quality of life. Secondly, in Canada, the life expectancy on average is about 80 years, but the health-adjusted life expectancy is 70 years. That's a 10-year difference. What it means is that on average, in the last 20 years of your life, you are in poor health. And third, in Statistics Canada, they have got this health utility index, which shows the quality of life. The range is from minus 0.36 to 0 to 1. 1 means perfect health, alive. 0 means death. And we believe that some diseases are associated with a worse than death situation.
I'm going to have to ask you to try to get to your question, please.
So the question is, how can we incorporate quality of life, disability, pain, and suffering into the equation?
Thank you.
Well, most of my comments were directed at low and middle income countries, and there, if you make a reasonable measure of years of life lost, which is mortality, and years of life with a disability, which is really expert-based estimates, mortality dominates, meaning that most of the premature combination of deaths and disability is really dominated by deaths. And if you think more sensibly about, well, if the framework is that if interventions and the systems that the panel very nicely argued are in place, then prior to old age, you can have a life of reasonably low exposure to the major risks, smoking, diabetes. That'll not only reduce the death rates, which you can monitor easily, but also in later life will lead to what epidemiologists described, and as you well know, compression of morbidity later in life. So in older age, yes, you can't avoid death, but hopefully you can avoid serious disability and have a quick, painless death. Now that all sounds depressing, but it's actually I think the appropriate way to think about how public policy should be. Heroic efforts at the end of life, towards the latter stage, might well improve quality of life, but I believe certainly that the main emphasis should be on reductions of premature mortality and of risk factors. That in turn will improve quality of life, in particular in older age.
Tim would like to add something.
Yeah, no, I think it's a great point. There's one point I want to make, which is first, we should be counting all lives and deaths, the vital statistics. Right? There are 135 million children born every year. Far too many of them are not even counted. Right? So there's a fundamental building block, which is really an insult on the integrity of a civilization in the 21st century, which is not every child that's born is registered and their life counted. But I think the opportunity moving forward is big data and technology, because there's no reason why if somebody has an immunization record and immunization coverage is 90%, that 90% of children can't be registered and their lives followed moving forward. But on the quality issue more generally, I think the other really important thing is just because infectious disease rates are very high in low-income countries doesn't mean that non-communicable disease rates, which have high morbidity, are not high. In fact, In low-income countries, often the age-adjusted incidence is higher in low-income countries than in high-income countries. So I think the point that you're making is that we really need to be looking at all causes of morbidity and mortality is absolutely right.
We have time for 2 more questions over here and then back on this microphone.
Today we've been hearing mainly about health-related ways to reduce the death rates forward to 2030, but I would suggest to you that currently we have counterindications from other factors. War, Syria, female infanticide, which has been mentioned, climate change, and because of all of those social and political instability, and all those factors, unless mitigated, are going to just wipe out any gains in deaths. So how can that be added into your approach?
Thank you. Prabhat?
If I may, I'd like to disagree with you. And the reason is if you look at the progress, it's despite the more recent years, the last couple of years of increasing particularly religious-based violence, the overall trends have been quite positive in terms of wars and reduction. Steven Pinker has documented this nicely. In terms of the other metrics, yes, we have an enormous challenge for climate change, but notwithstanding that, the overall levels of health that are attributable to adverse climates or things like air pollution is actually improving in many settings. So there are many ways to try to improve health, but the lessons learned from the last century are the things that are particularly within the health system, which itself is rather complicated to manage and to worry about all the dimensions that the panel has outlined. That's where I believe we should be investing. And going forward to 2030, I think of all the sustainable development goals, which is the one that we're most likely to achieve? I think it's going to be the health one, perhaps the education one, optimistically, but it'll be the health one. So let's focus on what we've done that has been working, and that's the way forward, I believe.
Just a brief rejoinder. I mean, I think one of the blind spots of health systems is that we're not well prepared to manage uncertainty. And I think this was absolutely clear in the context of the Ebola crisis in West Africa. Not only were there 11,000 deaths due to Ebola, but the deaths due to increases in infant and maternal mortality associated with basically the decline and elimination of basic health services during that crisis have had a huge toll. So I think one of the things that we've got to learn to be much better at is how do we prepare for some of these unforeseen but very likely crises. And in health space, this relates to pandemic threat. And I think we all of us everywhere need to think about the preparedness and response systems, and particularly from our perspective, the World Bank, how you finance those in such a way that you can get timely support in such a way that you mitigate spread of an outbreak before it becomes a pandemic.
Jillian would like to add
Just
something.
very quickly, I think also what your question's raising is the need to look at health in a more comprehensive way, which is being done. I think there is a multidisciplinary awareness that hasn't perhaps been there always. So I think some of the issues that you signaled were of concern are on the minds of people. We do have to be focused, but we also have to be kind of thinking outside of the box and looking at the other sectors and the other disciplinary approaches which could help feed us towards better solutions.
Paul.
And just to pile on, I think the point you make forces us to look at when countries emerge from violence, is the first priority to do something to restore health systems, education systems, feeder roads, or is it an advisor for the Minister of Finance? And the global development community has not been very good at making those choices. So hopefully we will learn something. Even the Ebola situation, in the place where it was worst, had civil wars. And the donors financed advisors as soon as the war stopped.
Dr. Dirks.
Prabhat, that was a great, outstanding lecture showing the vast improvements in public health and longevity over a period of time. I want to ask a question about world population. So we're about 7.5 billion now. By the end of this century, it'll be 11.5. You can just extrapolate beyond that if it was at all even close to being linear or less. Obviously, this relates a lot to health. I heard Bob Black say in San Francisco a month or two ago that, for example, in Africa, I think it was close to half the pregnancies were unintended. So there's a lot of opportunity to do something. And obviously, if you're thinking of climate change has just been raised, the more people, the more cars, et cetera, et cetera. So I've sort of got the impression the last decade or two this is a little bit off the public agenda, or much less talked about than other issues. Tell me I'm wrong.
Well, as I understood the estimates from the UN POP division, the latest one published in Science, I may be wrong on the numbers, but they predicted stabilization of the world population somewhere around 9 billion by 2050. I mean, the 11 billion, I think, is the worst case scenario. Now, in terms of, as we've understood, what are the drivers of getting reduced fertility, we've had an extraordinary and I think welcome change that's recognized, well, if you reduce child mortality, families will have fewer children. If you look around the world, the major dominant challenge is in Africa. Africa was so-called underpopulated to some extent, but rapid population growth now means that there is a challenge for reducing fertility in Africa. And I think you're right, it does need more attention, and it's been refreshing to see Melinda Gates in particular take a personal interest in saying, well, the foundation and its efforts need to draw more attention to the rights of women for access to good reproductive health services, getting more family planning efforts scaled up. But if you look in other settings, in India, for example, fertility has dropped substantially, and in parts of urban India, there in fact might have a challenge, which China already has, is where fertility is below replacement. And so these are dynamic changes. I think you're absolutely, they need to be incorporated. I think the main strategy continues to be, I believe, a health-driven one. You reduce fertility by reducing child mortality.
I think you would like to add.
Yeah, I would. I mean, I think there's a wonderful YouTube that Hans Rosling has done recently, which looks at Africa and in the context of the world population going to 11 billion by the end of this century. But it's a very positive interpretation and a little counterintuitive. But I think, one, it's based on what there's been tremendous progress. So the country that I spent a little bit of time in, Bangladesh, one of the world's greatest prophetic foreign policy experts, Henry Kissinger, deemed that Bangladesh was a basket case in 1971 when it was born. And that related to endemic poverty, way too many mouths to feed, fertility rates of over 6. And now it has a total fertility rate of 2.1. So its trajectory over the last 45 years has defied all of the experts' negative prophetic comments. It has gone beyond the Malthusian specter of massive famine. And so I think there's lots of reason to think that there is a lot of opportunity. I think Prabhat's prescription is absolutely right. Opportunities to health, opportunities to good nutrition. If we can get beyond 25% stunting in the next generation, then you're securing not only good physical growth, but also cognitive growth and development, which is going to be critical not only for completing education opportunities, but also participating fully in the 21st century economy.
Thank you very much. I'm struck by how this panel reveals something that was absolutely crucial in my knowledge of John Evans when he was president of the University of Toronto, and that was really a forward-thinking commitment to interdisciplinary work. He was really one of the leaders in Canada in trying to promote robust interdisciplinarity. As an international lawyer, I'm really encouraged that on this panel, which has entrepreneurs, health researchers, epidemiologists, we ended up having some controversy around questions around governance and inequality and organizing social assets. These are issues that actually cross out of epidemiology and into governance and into the kind of world that I live in. And I think that it's tremendously exciting to see this kind of discussion taking place in part, and in fact, in large part, because John Evans was here. So thank you very much. Howard, would you like to say conclusion?
One of our responsibilities is also to know our limits. And here, with all these representatives from so many different disciplines, it also struck me as we were talking about population that among the pieces of evidence that have been the most revealing has been the evidence showing that the most influential factor in lowering birth rates has not been reproductive policy, has not been the healthcare system, it's been the education of women. And so much of what we need to do has to relate to working with disciplines outside of health, outside of what we think of in the ivory tower of universities to actually make progress on all of these issues in an integrated way. I'd like to thank Stephen Toope for being a wonderful panel chair and our speakers. We really look forward to doing this again, and thanks for being a lovely audience on this beautiful day.